All right, welcome back. Today's study tip is called the bridging game. For all the terms in a chapter, write them on small pieces of paper, put them in a box or a hat, mix them up, and draw two out at a time and see if you can not only remember what those terms mean, but identify the relationship between them. So how are the two terms connected? What do they have to do with each other? Is there something they have in common? Maybe there's a concept that will tie the two together, or an organ system, right? So this is going not only to test your memory of terms, but your understanding of concepts. Okay, highly recommend it. You can play this by yourself, you can play it with another person, or even in a small group. Okay, so now we're going to finish chapter 11. We're going to talk about about 20 different hormones. You need to be able to tell me where it's produced, what's the target, and what happens when it gets to the target. What effect does it have on the organ? For a couple of these hormones, you'll tell me both where it's produced, where it's stored, and where it's secreted from. Most everything else, it's all the same. Production and secretion will be in the same place. But for the first couple we're going to look at, it is different. Okay, so two hormones that you need to know that are produced, so made by the hypothalamus, but then stored and released from the posterior pituitary. So you would say produced by hypothalamus, secreted by posterior pituitary. And these two hormones are going to be ADH, antidiuretic hormone, and oxytocin. So let's start talking about antidiuretic hormone first. We will talk more about ADH when we do our chapter on urinary system. For now, you just need to tell me that it will stimulate the kidney cells to reabsorb water. So the target is the kidney. It's going to cause the kidney to reabsorb water. That water, whenever you reabsorb water, it goes into the blood, okay? And if you're taking water from the filtrate and putting it in the blood, that means that you're not going to have that water for urine, right? So your amount of urine will decrease. So the total volume of urine decreases, and that means that the urine itself will be more concentrated, which you know of as being, darker in color when you urinate. Okay, so that's really all I have to say about ADH. Like I said, we'll talk about more about that in when we get to urinary. Okay, oxytocin has kind of two primary functions. The first is to stimulate contraction of the myometrium of the uterus, so the muscle of the uterus. So in women, of course, oxytocin is responsible for signaling contractions to start labor, okay? It also will increase the production of prostaglandins, which are responsible for moving labor along, increasing the intensity and frequency of contractions until you finally push the baby out, right? And of course, you guys know that it's not just about pushing. In fact, you don't push until you're completely dilated, right? So all these contractions are working to open up and create the space for the baby to be able to come out of the uterus, right? Okay, so opening up the cervix. Now, some women will have various reasons why they need to have labor to be induced, and we have a synthetic form of oxytocin that we use called Pitocin, Pitocin, Pitocin. So, for example, if a woman's water breaks, and then I don't know how many hours, but after a certain amount of time, if labor doesn't start, then it will be induced. Another scenario that can happen is that during labor, the contractions start to slow down and maybe even stop. So that would be another reason that Pitocin would be administered. There can be other reasons why you need to induce labor besides the two examples I gave, but those are the most common. Okay. Now, once the baby's born, oxytocin will promote lactation, right? So moving the milk through the breast so that the baby can get the food, right? So when the baby sucks at the mother's breast, oxytocin secretion causes the milk to release so that the baby can feed. At the same time, oxytocin is also released into the brain, and that will stimulate further oxytocin production. So this is positive feedback. Remember, we talked about positive feedback, and there are very few times that you see positive feedback in the body. This is one of them, okay? Please be careful not to confuse this with milk production. There are different hormones in control of milk production. Oxytocin simply is for the release of milk that's already made, okay? Once the baby stops feeding, then the production of the hormone stops until the next feeding, okay? Also, men do have oxytocin. It's not going to have as predominant of action, but it does seem to have some role in moving sperm and also in production of testosterone. But I don't think, I think there's still research that needs to be done or is currently being done. So basically, we don't really know exactly what's happening with oxytocin in men. Okay. Now, this picture is what we just talked about, right? The hypothalamus produces ADH and oxytocin. Then it travels into the posterior pituitary, where it will wait to be released. Also, the hypothalamus is actually the boss. It will decide when the posterior pituitary is supposed to release the hormones, which hormones and when, okay? So it's just kind of interesting that we have this extra step of storage and release from the posterior pituitary. Okay, so just remember that. Also, good time to review a little bit of your anatomy. Okay, so now we're going to talk about secreted by the anterior pituitary. And these are called trophic hormones. So they're produced by the anterior pituitary, but they are still controlled by the hypothalamus. So the hypothalamus is the boss that decides when you're going to release hormones. But this time, the anterior pituitary will do the work of production of the hormones, okay? And we're going to just look at a few examples of anterior pituitary hormones, a total of 6. We'll look at 6 hormones, okay? So the first, growth hormone. Growth hormone's also called somatotropin, and you need to remember that because there's an inhibitory hormone called somatostatin, okay? And so you need to remember both. Somatotropin is growth hormone, Somatostatin is the inhibitory hormone to inhibit the growth hormone. Okay, so what is it? Growth hormone promotes amino acids being taken into cells for protein synthesis. It stimulates the liver to produce somatomedins, which are needed to stimulate bone, soft tissue, and muscle growth. Of course, if you have too much or too little growth hormone, it can cause, I'm going to call them conditions. You might think of them as diseases, but let's be very gentle with what we say, right? Okay, so if you have over secretion of growth hormone while you're still in your developmental stage of life, then you will stimulate all of the tissues to grow, and you will grow proportionately, right? You will grow very tall. And so the first image that I have here is a woman who clearly had an overstimulation of growth hormone while she was still developing in adolescence. And I know this because once you become an adult, if you have too much, you will have, instead of gigantism, you would have acromegaly. And acromegaly will only affect the tissues that still respond to growth hormone, right? So the bone, the connective tissue, doesn't really respond to the growth hormone anymore. And so instead, you get structures like the nose, the lips. Some people will also have the brow and the chin grow. And this, we say that it causes disfigurement. And though we don't say that to be rude, but you can see a definite change in appearance from before and after for this woman, right? So I don't know why they put that, they kind of flipped the order of this, but this is what she looked like. She developed a tumor, benign, okay, and that caused the overproduction of growth hormone, okay? So the word for that tumor, that benign tumor, is adenoma, and that's ADENOMA, and that specifically means a tumor, a benign tumor of gland tissue. That could be the gland itself, it could be the epithelial tissue surrounding the gland, okay? And this, it's fairly common for these benign tumors, and we'll talk about another example of that later on in this lecture, okay? So adenoma, and so she developed that, and that did change her appearance. And so because adults cannot continue to grow in height, right, growth plates have closed and they're permanently closed, so only certain tissues will still respond. And as I said, that could be the brow, the nose, the chin, the tongue, the lips, hands, and feet, okay? And of course, once you don't have to wait for it to become severe like this. Once there are symptoms of change, right, you, or hopefully through your regular testing, you know, if you're getting a full blood workup every year as part of your physical, hopefully you would detect it before you even have any change in appearance. But in either case, you could be given somatostatin to inhibit the growth hormone and stop any further change. Okay, third category, dwarfism. And of course, this is something you're more familiar with, and I think we had a whole bunch of TV shows, or at least one TV show about dwarfs, which I believe is called Little People. I never saw it, so forgive me. But and this might be from that. I really don't know. I did a very quick search and took this picture off the internet. Okay, so this would be, of course, during adolescence, not having enough growth hormone. And you can have what they call proportional and disproportional dwarfism. And it turns out that proportional dwarfism is actually more common from having inadequate levels of growth hormone, whereas disproportionate has more complex causes. And with proportional, just means that the whole body is smaller than usual, whereas disproportional, you have kind of the torso is a normal adult size, will grow to be a normal adult size, but the arms and legs will be shorter and smaller. What else did I want to talk about? Of course, during childhood, you could opt to have injections of growth hormone so that you could develop normally. And there are other hormones that are regulated through growth hormone. So other anterior pituitary hormones would be regulated. So treatment with injections wouldn't be purely cosmetic, but actually, promote healthy endocrine system. Okay, moving on. I didn't mean to talk about this so long. Okay, trophic hormones secreted by the anterior pituitary in addition to growth hormone. There's thyroid stimulating hormone. There's adrenocorticotropic hormone. Adrenocorticotropic hormone is abbreviated ACTH, but also sometimes is shortened and just called corticotropin. Okay. And then after this, we'll still talk about FSH, LH, and prolactin. So those are the 6 hormones of the anterior pituitary that we're talking about today. Okay, so thyroid stimulating hormone, you're going to read a little bit more about that in lab. I'm not going to spend too much time talking about it, but of course it's secreted by the anterior pituitary, and its job is to stimulate the thyroid. And it will, when it stimulates the thyroid, it'll cause the thyroid to produce and release T4. T4 in the blood will be converted to T3, which is what regulates your metabolism. It increases metabolism. So if you have really slow, very slow metabolism, you have a weight gain, you're tired, one of the causes could be not having enough T4 secretion and therefore not having enough T3 to keep your metabolism at a fast enough pace. Likewise, you could have too much and you could be very thin, not be able to put on weight. We'll talk more about that later when we talk about thyroxine specifically. Okay, so adrenocorticotropic hormone, it stimulates the adrenal cortex to release glucocorticoids such as cortisol. So the production of ACTH is regulated by the hypothalamus, as is all the other hormones that we've talked about so far. Okay, and the hypothalamus specifically will release corticotrophin releasing hormone, abbreviated CRH. And when the hypothalamus releases CRH, that will stimulate the anterior pituitary to secrete ACTH. And then ACTH stimulates the adrenal cortex to release glucocorticoids such as cortisol. And we will talk about cortisol a bunch when we get to that in a few slides. Okay, follicle stimulating hormone, FSH, signals the ovaries for growth of ovarian follicles. Ovarian follicles develop and then leads to ovulation. Okay, FSH also is important in men, and that signals the testes to produce sperm. Okay, LH, also important for men and women. Okay, and remember, FSH, LH, originally studied and named after the female reproductive system, but equally active and important in men. Okay, so LH, ovulation and formation of corpus luteum. And the corpus luteum is the tissue that's left behind after ovulation. And we'll talk a lot more about this in the last chapter, the reproductive system. Okay, but for now, just know that LH and FSH are important for the ovarian cycle and ovulation. Okay, LH is also important for the testes to produce testosterone. So here we see a difference. The FSH is mostly for sperm production, whereas LH is mostly for testosterone. Okay, and now prolactin. Okay, so in prolactin, it stimulates the mammary glands to produce milk. And in men, it supports FSH and LH regulation. Okay, so prolactin is released when a newborn baby suckles at the mother's breast, causing the production of milk. This is a primary and most well-known purpose of prolactin, but it turns out prolactin does have a wide variety of functions still being studied, and examples, behavior. There can be some regulation of behavior, the immune system, metabolism, reproductive system, and other bodily functions. Okay, so it turns out that prolactin is very active in the body of men and women. So lots of research is taking place to learn about these interactions and regulations. Okay, so that was the anterior pituitary. And then this is a summary of just the anterior pituitary. So for the anterior pituitary, we talked about 6 hormones: TSH, ACTH, FSH, LH, growth hormone, and prolactin. Okay, so what's not on here is oxytocin and ADH, and that's because they're from the posterior. So if I were you, I would write onto this picture where it's pointing to the posterior pituitary ADH and oxytocin so that you can remember. And then you could even circle oxytocin and point to the breast here, and then you can make a note, milk release, and then you have a nice visual of the relationship between prolactin and oxytocin. Okay, all right, next, the role of the hypothalamus. I've already told you here that the hypothalamus is the boss, right? So it's the master gland. ADH and oxytocin are actually produced in the hypothalamus in neurons, cell bodies, actually. So the cell bodies of neurons in the hypothalamus produce ADH and oxytocin, which is very interesting, right? Very unusual. And then they will be stored in the posterior pituitary until this special reflex called neuroendocrine reflex causes their release. Okay. And so we call these neurosecretory hormones because they're produced by a neuron, and they're also secreted when activated through this reflex, this neuroendocrine reflex. Okay, next we have the other hormones that we talked about, the anterior pituitary hormones, and they're also controlled by the hypothalamus, but in this case, the hypothalamus will actually release a hormone which will command the release of one of the anterior pituitary hormones. So these will be specific, right? So there's one specific hypothalamic hormone that will cause the release of a specific anterior pituitary. So for example, TRH, thyrotropin releasing hormone, will stimulate the anterior pituitary to release TSH, to then stimulate the thyroid to release thyroxine. Okay? So all of the hypothalamus hormones that control the anterior pituitary, all of those names are going to be called a releasing or inhibiting hormone. So I'll have some name, such and such releasing or such and such inhibiting, right? So the example I just gave with TRH is thyrotropin releasing hormone. All right. And then this is just a reminder of your anatomy, right? This also shows the cell body that produces the ADH and oxytocin, right? And then this special reflex that will trigger the release of those posterior pituitary hormones. And now we also get to see the anterior pituitary, and it produces its 6 hormones that we talked about, and it sits there and waits until it receives a hormone from the hypothalamus that tells it to release it. And those 6 hormones that we talked about are all called trophic hormones, and they're controlled by the releasing hormones of the hypothalamus. Okay, so the role of negative feedback in the hypothalamus, using TRH and TSH as examples. Okay, so the hypothalamus is responsible for TRH, right, thyrotropin releasing hormone, and that hormone will stimulate the anterior pituitary to release its TSH, thyroid stimulating hormone. And of course, TSH is going to tell the thyroid to release thyroxine. Okay. At the same time, it does cause a stimulation of the thyroid, which causes it to grow a little. Okay. And thyroxine will increase metabolism, but thyroxine will also play an inhibitory role, and this is where the negative feedback comes in. When you start to get high levels of thyroxine, it will inhibit the responsiveness of the anterior pituitary to TRH. So even if the hypothalamus continues to secrete TRH, when you already have high levels of thyroxine, the anterior pituitary is not going to listen to TRH, okay? And the high levels of thyroxine will also tell the hypothalamus to stop releasing so much TRH, okay? And this is a really nice negative feedback system that it targets both, because I look at this in 2 ways. the amount of time it takes to inhibit the hypothalamus and actually decrease the hormone means that you already released the TRH and it's now acting and still having an effect. And then you're getting more and more thyroxine, and you don't want that. If you already have a lot of thyroxine, you don't want to make more. So by inhibiting the anterior pituitary as well, you get a more immediate shutdown, right? You get an immediate slowdown of thyroxine being released. This also, I look at it as being a backup. If one of the negative feedback modes of action is not being effective for some reason, you can look at it as a backup system, right? That you at least still have the other. So think of this like brakes in the car. If your brakes are not sufficient to stop the car, you have your emergency brake, right? Okay, so that is the hypothalamus pituitary thyroid axis, and this is an example of negative feedback. Okay. So this is just to recall the adrenal gland sits on top of the kidney, and then if you look at the adrenal gland, you can divide up the outer region called the cortex from the center called the medulla. And when you look at the cortex, you have these different layers, right? Okay. Now, for the adrenal cortex, there are steroid hormones that we're interested in. So the first group of hormones from the adrenal cortex are called the mineralocorticoids, and this includes aldosterone. And aldosterone is another hormone that we'll talk more about when we talk about the urinary system. It's important in regulating blood pressure, and it does this in an indirect way. So aldosterone is going to signal the kidneys to absorb more salt. And when it reabsorbs salt, water will follow it because of osmosis, okay? So then you increase the amount of water in the blood, and that increases your blood pressure, okay? So remember, water always follows salt. And that's as much as we need to talk about aldosterone for now, okay? Aldosterone increases the concentration of salt in the blood by signaling the kidney to reabsorb salt. Water will follow, and that will increase your blood pressure. All right. Now, you're probably wondering what these images are, and we will talk about those once we talk a little bit about cortisol. So the glucocorticoids are mostly known for cortisol, and some of the most known functions of cortisol involve gluconeogenesis and also anti-inflammation, or reducing inflammation. So let's talk about this a bit, because cortisol is one of those hormones that is both widely talked about and also poorly understood by most people. Okay, so cortisol is, as you know, one of the steroid hormones. So its precursor is cholesterol. It's made in the adrenal cortex. Okay, most cells within the body have receptors. Therefore, cortisol can have all sorts of functions because it can interact with essentially most of the cells in the body. Secretion of the hormone is controlled by, of course, the hypothalamus, but also the pituitary gland and the adrenal gland. So this combination, the hypothalamus, the pituitary, and adrenal gland are often referred to as the HPA axis, right? Hypothalamic, pituitary, adrenal axis, because they form a negative feedback system to regulate cortisol. Okay, so because most of the cells have these cortisol receptors, you're going to have all sorts of different functions. Cortisol can help control blood sugar. It can help regulate metabolism. It can help reduce inflammation. It can even play a role in memory formation. Also plays a role in salt and water balance to help regulate blood pressure. And then in women, there's also some role in fetus development during pregnancy. Okay. Moreover, the images that you see here show what can happen when you have excessive or high amounts of cortisol. You can get what's called a buffalo hump, which is a fatty fat deposits right on the base of the neck. Okay. And you can Google that and you can see more pronounced examples. I didn't want to give a crazy example. I wanted to give something a little more common. Not as severe as it could be. Also, you can get these striations or streaks on the abdomen. And so that's what this image is. You can have both, or you can have one or the other. There are also other symptoms, so let's go ahead and continue talking about this. So high levels of cortisol in the blood can cause rapid weight gain in the face, abdomen, and chest. Typically, you can tell because the arms and legs will be slender compared to the heavy weight in the face, abdomen, and chest. Okay. It can cause a flushed face, high blood pressure, changes to the skin. It can lead to osteoporosis. It can cause mood swings. It can change libido, especially in women. It can also affect women's menstrual cycle. And in both women and men can be linked to anxiety and or depression. Okay, so high levels of cortisol, not good, right? We also have to distinguish the cause of high cortisol levels. So you can have Cushing's disease, which would be a tumor of the pituitary, okay? And then the tumor in the pituitary means that you're going to secrete too much adrenocorticotropic hormone, ACTH, okay? And then having high amounts of ACTH will stimulate a lot of cortisol to be produced and released. That's Cushing's disease. You could instead have Cushing's syndrome, which would be a tumor of the adrenal glands or any other cause. So only the pituitary tumor is called Cushing's disease. All the other causes will be Cushing's syndrome. Okay, Cushing's syndrome is much more common, and that's it's kind of your catch-all, right? So there's more possible causes. So I don't want to say that it's more common to have a tumor in the adrenal gland than it is in the pituitary. You could research that. You could see if that's true. But I think the reason Cushing's syndrome is most common is because it includes other causes like cancers elsewhere in the body that make ACTH, or medications that contain cortisol, like hydrocortisone, prednisone pills, certain skin ointments will be cortisone in them, certain asthma inhalers, and even steroid injections for joints. Okay, all of that can cause Cushing's syndrome. Okay, so Cushing's syndrome, tumors of the adrenal gland, The adrenal glands will then make too much cortisol, or you could have cancer somewhere in the body that leads to ACTH secretion, okay? Or, as I mentioned, the medications. Okay. All right, so that was the second group, glucocorticoids from the adrenal cortex. Now, androgens and estrogens, I'm not going to spend too much time talking about. You're more familiar with these, but in males, the majority of their androgens will come from their testes, and for females, the majority of estrogens will come from the ovaries. But you do have some androgen and estrogen production in the adrenal cortex. And this makes sense as well because we know that both men and women have testosterone and estrogen, right? And so you might, if you didn't know that the adrenal cortex also produces these hormones, then you would wonder, like, how do we make testosterone, or how do men make estrogen, right? So now you know. All right, so now moving into the center, the adrenal medulla. These are the amine hormones, epinephrine and norepinephrine. Remember, norepinephrine is primarily a neurotransmitter, but it's also a hormone, right? It can circulate through the body. And epinephrine is what a lot of people refer to as adrenaline. Okay. So norepinephrine is primarily a neurotransmitter. It's produced by sympathetic nerve fibers, and it's stored in small amounts in adrenal tissues. Okay, specifically the adrenal medulla. Of course, you know of these hormones from your fight or flight response, right? So under an extreme stress situation, your body prepares for you to either run for your life or fight for your life, right? Both of these hormones are derived from the amino acid tyrosine, and they're in a category of hormones called the catecholamines, okay? And that's in your textbook. You can look at the chart in your textbook. Okay, so what does it do? It increases cardiac output and heart rate as well. So how much blood with each pump is pumped out of the heart would be the cardiac output, whereas how many how many pumps per minute would be your heart rate, okay? Vasodilation is going to open up the diameter of your blood vessels to increase blood flow. And of course, primarily, this is going to take place in your skeletal muscles, so that you have plenty of blood supply for those skeletal muscles to do work, right? And you're also going to increase the ability of your skeletal muscles to contract, okay? You're going to get increased mental alertness. This alertness might make the difference between survival or not, right? Increased metabolic rate. You're breaking down your stored fat, you're breaking down your stored sugar, you're increasing your blood sugar, which makes sense because your skeletal muscles are probably going to need the extra supply so that you can, like I said, fight or run away. Okay. So I know we talked about a lot of different hormones produced in the adrenal gland, and they come from different categories of hormones. So this is a nice summary for you. There's nothing new here, just a summary. Okay. All right, thyroxine, as I said, we would talk more about it. So in this image here, you have your thyroid gland, okay, and production of TSH from the anterior pituitary signals the production of T4 and T3. Mostly T4, and then T4 is converted into T3 in the blood. Okay, and there are follicular cells of the thyroid that are responsible for making the T4. And in order for them to do that, they need adequate supply of iodine and tyrosine. Okay, so this is, as I mentioned in the previous lecture, why we add iodine to salt is to make sure that you can produce your T4. If you don't produce enough T4, the thyroid is going to continue to be stimulated, and then it's going to enlarge more and more. Okay, and once it's enlarged to a visible amount, it's referred to as a goiter. And I have a picture of that on the next slide for you. So we can kind of get away without having iodine in our salt because we do have better diets, but it used to be very common for people to get goiters. Now it's mostly only seen in other countries where they don't have adequate food supply, but I still recommend that you occasionally have some salt with iodine just to be sure. Like, why would you put yourself at risk, right, unnecessarily? Now, let's see. There's a couple other food items that I could mention as a little side note, that it's common that there's additives to try to prevent different health issues, right? So, like milk is known for vitamin D, but that's not natural. Milk doesn't come with vitamin D, it's added to it. But if you have, I think it's about 15 minutes of sun a day, you will make all the vitamin D that you need. Folic acid is another additive, and you'll see that added into a lot of foods. And it's really important for neurodevelopment and a lot of other aspects of development. So when you see prenatal vitamins, they're going to have large amounts of folic acid. When you see daily vitamins, they'll have some folic acid as well. Processed foods like cereals tend to have folic acid added to them. Now, I would say you don't need the vitamin D and folic acid supplements because you can easily get that in your diet. The iodine, you're probably fine because we do have better diets, but that's the one that, what do you know what foods are rich in iodine? Do you know for a fact that the foods are coming from soil that hasn't been over farmed? Because as you grow crops over and over again in the same soil, you strip that soil from their nutrients, and then your food won't have as much nutrients. This is also why fertilizers became so popular, was to supplement things, only certain things in the soil to make plants still grow, but doesn't mean that it's balanced. Okay, back to endocrine. Okay, so functions of the T3, T4, right? So T4 thyroxine, as I told you, T4 will mostly be produced by the thyroid and then converted to T3 in the blood, and this is going to increase your metabolic rate. Your heart rate will increase, your growth will increase if you're still growing, and your body heat will increase. And of course, the body has the negative feedback loop to turn off TSH when you have sufficient or high levels of T4. Okay. So here's T4 and here's T3. You see they're very, very similar. And I don't want you to memorize their structures. I just wanted to remind you that after the thyroid secretes T4, it's going to be converted to T3, and that is what will elevate your basal metabolic rate. And your basal metabolic rate is where the majority of your calorie expenditure comes from. Okay. So when you have sufficient or elevated levels of T4, that's going to raise your T3, that's going to raise your metabolism, so you're going to have an increased rate of protein synthesis, you're going to have an increased rate of cell respiration. All of these activities are going to increase your body temperature. Okay, and you either already studied this for your PhysioX or you're going to after this lecture. And then I told you that if you keep stimulating the thyroid with TSH, but you don't have iodine or you don't have tyrosine, you can't make enough T4 to turn off the pathway. So you keep stimulating the thyroid, and it's going to enlarge more and more. And it might enlarge on one side more than the other, or it could enlarge on both sides. And so we have an image of a goiter here and here. They can get very, very large. You could Google that for your own curiosity. They can be much smaller than this, right? And then they can get very large. And like I said, you just need the iodine, and you don't have to have a goiter. Okay. So now it's time for you to do a little work with everything you've learned and with everything you already know. Tell me what you think hypothyroidism is and hyperthyroidism, and what would the symptoms be? So if a person had hypothyroidism, what would you expect? If a person had hyperthyroidism, what would you expect? And I already talked a little bit about this, but taking into account what you know about regulation of metabolism, what you just learned, I want you to pause the video and answer this question. Okay, so I'm going to trust that you paused the video and you wrote down some of your thoughts on hypo and hyperthyroidism, and also how you could detect and treat these diseases. Okay, so hypo means less than, hyper means more than, right? So hypo means slow, underactive thyroid. You don't have enough T4 production, so you're going to have weight gain because you have a low metabolic rate. Your heart rate is going to be slow. Your body temperature, right? You're not going to have as much heat production, so you're probably going to be cold. You have very little energy, feel very sluggish. If this happens during developmental years, then growth will be slowed. Simple blood tests check the concentration of the T4, T3 in the blood. And if it's too low, then you can take synthetic or what we call bioidentical hormones to supplement and get it back into a normal range. And it's not really considered dangerous. It's unwanted, right? You have low energy. Of course, if weight gain becomes too excessive, then that would be a medical concern. Everything else is more just, what a bummer, right? To have low energy. But hyperthyroidism is actually dangerous. So hyper means overactive. You're producing too much T4. You have too much stimulation of your metabolism, so you cannot put on weight. You're going to have a low weight, very high metabolism, high heart rate, and high body temperature. And this high heart rate is where the danger really lies. You're putting a lot of strain on the heart. And even someone who's very fit and takes very good care of himself can suffer from this. In fact, we know of an athlete, and I want to say Olympic athlete, who was a runner, and she had hyperthyroidism, and she died early, very early, I believe, from the strain on her heart. Okay, so just because someone is thin doesn't mean that they're healthy, right? All right, so another thing is, in addition to not being able to gain weight and being thin, you might even see the eyes might bulge a little bit. Okay, so that's interesting. All right, so we're almost done. Calcitonin. Calcitonin is a hormone produced by the C cells of the thyroid, and they're going to decrease the amount of calcium in the blood by inhibiting osteoclasts. Osteoclasts are cells that remove calcium from the bone. So when osteoclasts are active, you're going to have more calcium in the blood. When you inhibit osteoclasts, you're going to have less calcium in the blood. In addition to this, calcitonin will also inhibit the kidneys from reabsorption of calcium. So you're going to excrete more calcium in your urine, and you're going to stop pulling it out of the bone. So that is, those are both two ways that calcitonin will lower the calcium in the blood. Okay, parathyroid hormone is going to do the opposite. It's going to increase the calcium in the blood. So parathyroid hormone is produced by the parathyroid gland. Okay, and this has always been interesting to me. The parathyroid glands are glands on a gland. Parathyroid are on the thyroid gland. Okay, and when you stimulate the parathyroid gland to release parathyroid hormone, this is going to do three main functions. It's going to remove calcium from the bone to release it into the blood. It's going to tell the kidneys to reabsorb calcium, again, to put it into the blood. And it's also going to tell the intestines to absorb more calcium, and again, to put it into the blood. So this is going to stimulate osteoclasts to remove calcium from the bone. It's going to increase your blood calcium levels. Okay, but it's also going to tell the kidneys to reabsorb calcium and the intestines to absorb calcium as well. Your book has this because we've really been trying to teach you guys negative feedback loops. You should definitely know this. But another way to look at this is in this diagram. Okay, so we'll start with the one in your book and then we'll move over here. Okay, so if there are low levels of calcium in the blood, the parathyroids will be stimulated and secrete parathyroid hormone. This is going to signal the kidneys to reabsorb more calcium, and it's going to signal the bone to break down and release calcium. And of course, you know that's done through the osteoclasts. Both of those processes will increase the blood calcium levels. And by reabsorbing calcium from the kidney, you're going to have less in the urine. Once you increase the calcium in the blood enough, that will have a negative feedback effect, inhibitory effect, and basically lower or stop the parathyroid hormone secretion. Another way to look at that is about having an imbalance and trying to get your balance back and So why don't we start here? You have an imbalance, and that imbalance is detected by the parathyroid gland, and in response, it's going to release parathyroid hormone. So your amount of parathyroid hormone is going to increase. That's going to tell osteoclasts to take calcium from the bone. It's going to activate the osteoclasts, and then that's going to increase the amount of calcium in the blood. But once you get enough or too much calcium in the blood, then that's another imbalance, which is going to tell the thyroid gland that you have too much. And so then it will decrease the parathyroid hormone. And then that will allow you to make more calcium deposits in the bone and inhibit osteoclasts. And this continues. And you always are going to be switching back and forth. You're going to do a little, you're going to remove a little, and you're going to add a little, right? Constantly. And these levels constantly change because your activity changes and your diet changes, right? So constantly in flux. And that's the beauty of negative feedback loops, is it's not a solid on or off, but it's like adjusting the faucet. You can think of like having a little bit more or a little bit less cold water, or a little bit more or a little less hot water, so that you can maintain that perfect temperature in the shower. All right. Pancreas. The pancreas is responsible for both insulin and glucagon. Glucagon is made by the alpha cells of the islet. And here is your pancreas. And on the next slide, actually, did I remove it? No, here it is. Here, they show looking at your pancreas, and then looking at one of the islets, and you have the beta and the alpha cells. And I know you already know that from anatomy. So what's the purpose? The purpose is to take glucose out of storage. Remember, I've said this a lot. When your glucose is all gone, you need glucagon. Right? And then that serves to break down your glucose reserves. Glucose reserves are glycogen. So you break down your glycogen, you release the glucose into the blood, and so then you increase your blood glucose level. On the other hand, when the body senses that you have glucose in your blood, it's going to stimulate insulin from the beta cells, and that's going to stimulate glucose transporters, and then you can take the glucose out of the blood and into your cells. And if you have more than you need at the moment, then you will make glycogen and store it up. Okay? And essentially, by taking the glucose out of the blood and into the cell, you are decreasing the blood glucose levels. And so, just as I mentioned a moment ago, you are constantly turning on and off so that you'll have more or less of these hormones, so, because you want to maintain your glucose level, right? You don't want it to be too high or too low. And so this image here is nice because it shows when your blood glucose is low, then you're going to need the glucagon secretion. And when your blood glucose is too high, you're going to want insulin. Okay? So the relationship between the liver, your muscle, fat, and your pancreas, right? So what's the liver have to do with it all? Well, the liver is the only organ that can release glucose into the blood, right? Besides when you eat and you absorb it through your intestines, okay? But as far as when you don't eat and your glucose levels drop, the only organ that has the ability to release glucose is the liver. And when you have plenty of glucose, then you will store up glucose. It can be transformed into fat, or it can be stored up in the muscle as glycogen. Okay, almost done. Diabetes, when you are not able to make insulin, it's called type 1. Why would you not make insulin? It's an autoimmune disorder. Basically, your immune system destroys the beta cells in the pancreas, and then you're not able to make enough insulin to regulate your blood sugar. So people who have type 1 diabetes do not make enough insulin, and therefore they have to inject it or have a pump to inject it. This is most common onset in children. We do have older, right? It doesn't have to be children. We do see adults get type 1, usually if they've had some type of flu or other illness that has triggered an autoimmune disorder to happen. And this actually happened to one of my good friends in her mid to late 20s. She became type 1 diabetic after having precisely, she had a really bad case of the flu. All right, type 2 diabetes. This is the most common type, especially in the United States, where obesity is the highest in the world. This is because of the reduced sensitivity of insulin receptors to insulin. So type 2 diabetics make plenty of insulin. You would never give insulin to type 2 diabetics. It's not going to help them. They need something to help them use the insulin that they have. And so these are typically pills that they take. A common drug is called metformin, but there are various drugs. This is completely reversible. It usually takes 1 to 2 years to lose enough weight and have good exercise and a good diet, and lose enough weight and keep it off. And then you'll find that you need less and less of the metformin. You're able to maintain your blood sugar better and better until you are off the drug completely. And then, so of course, you can prevent type 2 diabetes by not becoming overweight. If you do become overweight, be very aggressive about getting a healthy diet, healthy exercise. Okay. I thought that was the last slide. We still have some more. Okay. The pineal gland, shown here, right here, very tiny. Okay. It will produce and release melatonin. Melatonin has a very important role in your night-day cycle, circadian rhythms. When you're exposed to light, especially sunlight, but any light will do, you actually inhibit the melatonin. And when it becomes dark, you start to produce more melatonin. Okay? And I put a little video here for you to watch. It's short, and it talks a little bit more about this dynamic of melatonin. Okay. Oh, and then this image here, hopefully this didn't scare you. It's just to show that tryptophan is a precursor to making melatonin, and this could explain why it said that tryptophan makes you tired. I think the more logical explanation is that people eat too much turkey at Thanksgiving, and the large meal makes them tired, right? But if you wanted to do a test, you could eat some turkey without all the stuffing, potatoes, yams, blah, 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 right? And then you could see if just having a regular portion makes you tired. blood cells, including the T cells. The T cells will then travel to the thymus to mature, and then they will go throughout the whole body and do their job. The majority will live in your lymph nodes, in the lymphatic system. We will talk more about all this when we talk about immunity. So you might be wondering, well, how do we fight infection when we're older? Well, you should know that as you age, especially with the pandemic, we've seen people over 50 and 60 are most vulnerable. This tends to be true for most things. As you get older and older, you lose function. Okay, but we do still have red bone marrow as adults. It's just mostly going to be in the flat bones, like the rib cage. Okay, and not so much in your long bones. Okay, you learned all that in anatomy, right? So the thymus produces thymopoietin, and thymopoietin is the hormone that encourages the stem cells in the red bone marrow to become specifically T cells. Okay, and then the T cells, like I said, go to the thymus to mature. So it starts with the hormone from thymus, which talks to the red bone marrow. You get T cells, and then that T cells goes back to the thymus to mature. Okay. Next, the gonads, ovaries and testes. Okay, ovaries are going to make the majority of estrogen. Estrogens, of course, are responsible for female characteristics, whereas testosterone is going to be produced from the testes and responsible for your male characteristics. More about this in the last chapter of the class. All right, here is your chance to put it all together, and I want you to spend a good amount of time on this. Pause the video and answer the questions. So this morning at 8 a.m., Martin and his friend Andrea went out to breakfast. Martin had a cup of coffee, and that was it. But Andrea knows it's important to have a good breakfast, so she ate yogurt, pancakes, fruit, and hot tea. Of the hormones discussed today, which ones will be increased or decreased by the breakfast that Martin had, which was just coffee? And then repeat the same activity for Andrea's breakfast. And you can use this chart to help. Okay, so here's a list of hormones. And you may say, this hormone shouldn't really be affected by what you eat. And that's valid. You can put a dash or in A. And then for others, you'll say, oh, it might be increased or decreased. And go ahead and work on that. And then unpause the video when you're done, and I'll reveal the answers. Okay, so here's the answer. So LH, FSH, right, sex hormones, estrogen, testosterone, even melatonin, those really shouldn't be affected. Thymopoietin shouldn't be affected, right? But things like your corticoid, right? When you don't eat, that is if you've gone too long without food, that is a stress. And now your stress hormone is going to increase, right? Same thing with epinephrine. You can have a little increase in epinephrine. Your metabolism, on the other hand, is being told to slow down because you don't have enough food, right? And so you can go through each of these and you can think about why they make sense. All right, hopefully you did well. Rewatch as many times as you need to, and let me know if you have any questions. Bye. Here's a summary of all of the hormones you need to know. It's 21 hormones for chapter